Here we will discuss about acute renal failure or ARF. Acute renal failure or ARF is a sudden and almost complete loss of kidney function over a period of hours to days. So acute renal failure is a sudden loss of kidney function and sometimes complete loss of kidney function, which may be over a period of hours to days. It may extend up to hours or days. So you can see decreased glomerular filtration rate, the kidney function will be damaged and it will be for a period of hours to days. That is acute. Causes. The causes we can divide into different group. The first one is pre-renal failure. Pre-renal failure means it is due to the causes which is happening before the kidney. It is not the problem with the kidney, because some other problem which is before pre-renal, that is the meaning of pre-renal, before the kidney. So this problem is before the kidney, or you can see these problems not in the kidney, before reaching kidney. So that is called pre-renal failure. You can see hemorrhage. When there is hemorrhage, then renal losses like diuretics or osmotic diuretics, or gastrointestinal losses, example vomiting, diarrhea, nasogastric suction. Then myocardial infarction, heart failure, dysarrhythmia, cardiogenic shock, sepsis, anaphylaxis, then antihypertensive medications or other medications. So in all these cases, you can see there is no problem with the kidney. The problem is somewhere before the kidney. So here, most of the case here, what is happening? There will be less fluid or less blood supply or blood flow to the kidney. So that is the reason for renal failure. So less blood, if there is less blood is flowing to the kidney, then automatically your kidney will be get damaged. I mean, there will not be adequate glomerular filtration happens, so the kidney will get problem. That is why this causes we can call pre-renal failure of the systems before the kidney. Second is intrarenal failure. Here the problem is within the kidney. Example, pigment nephropathy, myoglobinuria, example trauma, crush injury, burns, etc. Then hemoglobinuria, then aminoglycoside antibiotics, radiopaque contract agents, heavy metals, then solvents and chemicals, some NSAID drugs, then angiotensin converting enzyme inhibitors, ACE inhibitors drugs, then acute pyelonephritis and acute glomerulonephritis. So in all these cases, the problem is in the kidney. Maybe there will be some block because of this pigment nephropathy. There will be some block, and if you see here, you can see infections, acute pyelonephritis or acute glomerulonephritis means infections in the kidney. So because of these infections or some of the problems will cause a block in the kidney. So these will create problems in the kidney. Sometimes some toxic agents or heavy metals or some drugs, this will affect the functions of the kidney. So these are intrarenal failure because these problems or the causes are within the kidney. Next is post-renal failure. Here the problems is after the kidney. You can see the problems are after the kidney. I mean, there will be stones, tumors, benign prostatic hyperplasia, strictures, blood clots. All these you can see maybe in the ureter or urethra or ureter. So these problems lies after the kidney. So due to these problems also your kidney may get damaged. So there are three different categories: pre-renal, intrarenal and post-renal. Let's see the phases of acute renal failure. There are four phases: initiation, oliguria, diuresis and recovery. Initiation means when your kidney get the first damage. That stage is called initiation. Because of various reasons your kidney get damaged. That is initiation. Oliguria means after that there will be less urine formation or less production of urine will be there. Oliguria. You can see oliguria means less urine. Then you can see diuresis. Diuresis means it is a sign that your kidney is now becoming normal. In diuresis, Before the urine production was very less. Now the patient is having more urine, or it is coming to the normal level, that is diuresis. The urine level is increasing, that is diuresis. Then recovery. So diuresis, which shows that the patient is going to the normal stage. Recovery means the patient is getting complete recovery. So these are the 4 clinical phases of ARF. ARF you can treat, and it is reversible. It will come to the normal function or normal level. Clinical manifestation, you can see oliguria. Oliguria means urine less than 400 ml per day. 400 ml per day of urine, that is oliguria. Note it. Anuria means absence of urine, which means less than 50 ml per day of urine. Less than 50 ml per day of urine, that is anuria. Hematuria, as you know, hematuria is blood in the urine. Hematuria. Then low urine specific gravity will be there. Then increased blood urea nitrogen, that is BUN, blood urea nitrogen, and creatinine level. When you check the blood urea nitrogen and creatinine level, it will be increased. This condition is otherwise called as acetomia. Then hyperkalemia. Hyperkalemia means increased potassium level, because when your kidney get damaged, the potassium level will be increased in your body. So this is hyperkalemia, which is the dangerous or complication of ARF. Hyperkalemia, not the point. Because of hyperkalemia, or because increased potassium in your body or in the blood, you will have dysarrhythmia, cardiac arrest. So this dysarrhythmia and cardiac arrest is mainly due to this hyperkalemia. Then metabolic acidosis will be there, because your kidney is having a function of maintaining acid-base balance. So once your kidney get damaged, it cannot maintain the function, so there will be acidosis. Then increase in serum phosphate and decrease in calcium level. Increase in serum phosphate automatically will cause decrease in calcium level, because if the phosphate level is more in your body, then automatically the calcium level will be decreased. Then anemia due to reduced erythropoietin, because kidney which is helping for the production of erythropoietin, this erythropoietin is helping for the production of red blood cell, RBC. So once your kidney get damaged, there will not be adequate erythropoietin, automatically patient will get anemia. Management. First one is maintaining fluid balance. You have to maintain the fluid balance. You have to check patient weight. Then avoid fluid excess. Do not give more fluid to the patient. Avoid fluid excess. Then dialysis. This is the important one. Dialysis. These are the main 3 management. Apart from this, you have to treat hyperkalemia. Before I told you, hyperkalemia is the most life-threatening complication. Hyperkalemia is the most life-threatening complication. So you have to do an immediate management for the hyperkalemia. Otherwise, patient will get a lot of complications. So what we will do to treat hyperkalemia? You can administer cation exchange resins. Example, sodium polystyrene sulfonate. It is otherwise called as K-oxalate. You may be heard about K-oxalate. So this K-oxalate you can give orally or by retention enema. So this K-oxalate will help to reduce the potassium level in your body. Okay, K-oxalate. Remember K-oxalate, orally or by retention enema. And you can do immediate dialysis. So by doing immediate dialysis, you can remove the potassium from body. Then IV, intravenous glucose and insulin, or calcium gluconate. These also will help to reduce the potassium level. Then sodium bicarbonate also may be administered. So these are the management for treating hyperkalemia. Why we are treating hyperkalemia? Because hyperkalemia is the most life-threatening complication of IRF. So you have to treat it immediately. Otherwise, patient will have more complications. Then other management for IRF is you can give diuretic agents. Then low dose dopamine you can give. Then proteins are limited. You can't give more protein. You have to limit or restrict proteins. Proteins are limited to about 1 gram per kg, because these proteins, after metabolization, there will be production of urea, nitrogen, etc. So you have to reduce proteins. You can give high carbohydrate meals. To maintain patient nutrition level, you have to give high carbohydrate meals but restrict proteins. Then food and fluids containing potassium or phosphorus are restricted. As I told, patient is already having hyperkalemia, so you have to restrict fluids containing potassium or phosphorus. Example, banana. If you check banana is having more potassium content, so avoid these type of foods. Potassium intake is usually restricted to 40 to 60 milliequal per day. Thank you.